So this graph shows data up till about 2016, but we now know, even for recent data as of last year, that patients born within that 22 to 23 week window have a very, very high incidence of BPD, and it's well over 80% at this point. So we do think that the incidence of BPD is increasing because we are improving our survival of infants born extremely preterm, which you can see here in part B of this first graph. Additionally, what we know about BPD is that it's highly resource intensive, it's associated with mortality, and it's associated with lots of morbidities. So the mortality rate for patients with severe BPD is varied, but ranges between 10 and 20%. There are many morbidities such as tracheostomy dependence, neurodevelopmental impairment, growth failure, difficulty establishing feeds, pulmonary hypertension, and many more. And unfortunately, BPD outcomes vary depending on where the patient is. And so in this second graph, this was a study conducted by Dr. Murthy and colleagues, and they found that the center itself was predictive of larger outcomes such as mortality and tracheostomy. So the outcome of a combined death or tracheostomy ranged from 2 to 46%, depending on where the patient was treated. And this is just a huge problem, and a very large goal within the BPD community is to one day have more of a universal, standardized approach to BPD management, like the management guidelines that exist for CF or asthma, so that we can really make sure all patients, regardless of where they're treated, have the best possible outcomes. So it's well established that infants who have suboptimal growth, whether in utero or postnatally, are at a much higher risk of developing BPD. And this is multifactorial, but one component of this association is that these infants have minimal energy reserves when they're born. They have reduced key nutrients when they're born that are critical to lung growth, lung vascular growth, and lung repair. And then usually they're very sick early on, and they don't always have the best nutritional delivery early on in life. And there has been extensive research that's gone into how nutritional interventions may reduce the risk of developing BPD. And there are many nutrients that have been studied that have no association, but there are a few that have. For example, vitamin A is probably the most well-known. It is an important regulator of normal lung growth, and supplementation of vitamin A has been shown to reduce the incidence of BPD. I see that asked as board-style questions all the time, so make sure to remember that. Vitamin D has anti-inflammatory properties and is important for lung growth and lung repair as well. There have been a couple studies that show early supplementation of vitamin D within the first 4 weeks of life has been shown to reduce the incidence of BPD. And vitamin E is known to reduce free radicals and oxidative stress. And there have been a couple studies that show when you supplement patients in those early phases of RDS with vitamin E, it can modify their risk of developing BPD later on. Lastly, inositol acts as an antioxidant, and this is involved in things like surfactant synthesis. It promotes endothelial cell growth, and supplementation of this has been shown to reduce BPD incidence as well. So while these are all really promising studies, they're still small studies. They're still early studies apart from the work done with vitamin A, and we really just need more research to determine if and how we can best incorporate these interventions into routine clinical practice. So for patients that go on to develop BPD, so they have BPD, it's established, we know that suboptimal growth is unfortunately very, very common. And we know that suboptimal growth really impacts both short and long-term outcomes for our patients. It really impacts how the lungs are able to heal and grow. And we have data now that shows growth outcomes really impact pulmonary functioning later on in childhood. For example, this is a study that showed patients who have BPD that have catch-up weight gain had better longitudinal pulmonary function testing when you compare that to patients with BPD that had below average or even just average weight gain. And these two graphs correspondingly look at the forced vital capacity and the forced expiratory volume in 0.5 seconds specifically, with the open circles representing those with BPD that had below average or average weight gain, and then those closed circles represent patients who had catch-up weight gain patterns. So I would argue too that linear growth is actually even more important than weight growth. And we know that linear growth is particularly impactful as it has been shown to be associated with lung growth, with improving overall clinical stability, with the ability to wean respiratory support. So patients who have better linear growth trends are easily able to extubate or transition from non-invasive positive pressure to low flow oxygen. And we also know that linear growth has been associated with long-term improvements in lung function as well. For example, this is a different study. This study showed that improvements in height velocity was significantly associated with improvements in pulmonary function testing. And this was done within the first 2 years of life. And these are all patients with BPD. And interestingly, in this study, the authors did not find an association between weight growth and improved pulmonary function, but did find a very significant improvement with pulmonary function associated with linear growth. So we also know that for infants born preterm, regardless of BPD status, nutrition and growth has been well associated with neurodevelopmental outcomes. Weight, length, and head circumference have all been independently associated with long-term neurodevelopmental scores. And this is a graph from a study that examined Bailey composite scores between 22 and 26 months of age in former preterm infants, and found that those with linear growth restriction, represented here as LGR, had lower scores, especially in the language score domain. And this is just one example, but there have been many different studies that have shown similar findings, with examining Bailey scores. And we also know that there's evidence in the literature that shows improving weight and head circumference trends in the NICU are associated with a lower risk of developing cerebral palsy as well. So while a lot of this literature is not specific to BPD, there is, of course, the crossover as our patients with BPD are born preterm. So we know that undernutrition also impacts the patient's immune function, and this places them at increased risk for infection. We know that infection can then in turn worsen growth status because it increases energy expenditure and it causes protein catabolism. So we know that there's this delicate balance between undernutrition, infection, and inflammation. And unfortunately, in patients with BPD who are already very sick, infection can certainly lead to mortality, and it can lead to worsening inflammation that really impacts how lungs heal and grow. Also, we know that undernutrition is closely linked with chronic inflammation. So patients with BPD have underlying amounts of chronic ongoing inflammation, regardless of whether they have an infection or not. And we know that this inflammatory state can suppress insulin-like growth factor, which leads to further growth suppression. So this too is just a very bad cycle. And then we also know for infants who are born small for gestational age or have postnatal poor nutrition, they are at a much higher risk of developing BPD-associated pulmonary hypertension. And pulmonary hypertension within BPD and infection are two of the most common etiologies of mortality for our patients. So nutrition is just so important in their prognosis. So there are many growth challenges, as you all know, within BPD and getting our patients to grow. We know that from a very early age, patients with BPD, unfortunately, have inadequate calorie and protein intake compared to preterm infants who do not go on to develop BPD. And this is seen even within the first month of life. So this is a study that examined the nutritional intake during the first month of life between a non-BPD group and a BPD group. And they further differentiated this into those who had malnutrition and those who are well-nourished. And I've only included the findings that were statistically significant. And these are based just solely on whether you have BPD or you don't go on to develop BPD. And what they found was that for those patients who went on to develop BPD, they had lower calorie intake, lower protein intake, and took a much longer time to reach full enteral feeding. And unfortunately, this risk for inadequate caloric intake continues as well as the patient goes through the NICU. As I'm sure you've seen with your own experience, patients with BPD who are clinically unstable or have periods of infection or have, BPD spells, often enteral feeds are stopped. They're stopped quite routinely, and sometimes it takes quite some time before enteral feeds are reintroduced, and usually when they are, they're reintroduced slowly. So unfortunately, between that and the chronic fluid restriction that most of these patients are prescribed, just in general, they don't receive as much nutrition as they should, even from the beginning. So there are a few small older studies in the literature back into the 1980s that looked specifically at how much energy patients with BPD are using in their day-to-day life. And those studies did show that patients with BPD did have higher energy expenditure. This is most likely because of the work of breathing that patients with BPD have. This certainly is worsened by frequent respiratory weaning. So always putting these patients in states where they're being challenged and they're working harder to breathe. Just, of course, as you imagine, uses up more energy and more calories. And we also know patients with BPD have many periods of acute illness, have this baseline chronic inflammation, and frequently get infections. And all of this impacts how nutrition is used within the body. And also, even with patients that are stable from a respiratory standpoint and are like low flow cannula working on feeds, even those patients tend to have poor feeding endurance and tend to use more energy while learning to feed. So from the very beginning all the way through to discharge, these patients usually do require a little bit more energy in terms of calories and protein intake than preterm infants that don't develop BPD. So our goal is to have patients that look like this sweet little boy here that are, comfortably working to breathe, not having a lot of, work of breathing, not having a high respiratory rate, that are at baseline in a very quiet, alert, interactive state, able to work on developmental therapies and ultimately able to grow. So additionally, there are certain medications that we all use to manage infants with BPD that can certainly be growth suppressive, especially diuretics and corticosteroids. So prolonged diuretic use can result in more of a chronic electrolyte disturbance that can negatively impact growth and certainly bone mineralization as well. Specifically, patients who have a chronically low sodium tend to have poor growth and increased protein turnover. Corticosteroids are far worse, however, than diuretics, which we all know clinically that when patients are on steroids, their growth just drops off. And that's because corticosteroids at a more cellular level really increase protein use, reduce protein accretion, and alter how lipids are metabolized. So this usually leads to either poor growth overall, or patients like this one here, where they have increased fat masses, but very poor linear growth. And this is a study that looked at infants with chronic lung disease treated with dexamethasone. And it showed that those patients that were treated with dexamethasone had significantly lower growth rates compared to the placebo group. And this was even in the setting of both groups having similar energy expenditure, similar energy intake, and an overall very balanced energy picture. Um, and we see this all the time, where even if we're giving them adequate calories, and even if they're not exhibiting more signs of energy expenditure, even on, we can't modify anything to help them through when they need steroids, because regardless of the energy we give them, they're still showing signs of growth failure. This is another study that looked more at protein regulation. And this graph shows on day 0, before dexamethasone was used, the nitrogen intake, which is that open bar at the top. And then it shows the nitrogen excretion, the urinary nitrogen excretion at the bottom. And then the solid filled graph right next to it represents the amount of nitrogen retention. And so at the start of the study, you can see kind of baseline nitrogen status. And then certainly on day 4 and even extending into day 19, those patients who were treated with dexamethasone really, even in the setting of increased nitrogen intake, had a much higher nitrogen excretion and a much lower overall nitrogen retention. So I just think this is really important to consider anytime we're talking about doing a course of DART, because, or even when doing a course of prednisolone, honestly, just to a much lesser effect, because ultimately every decision we make for these patients has consequences. And certainly we see with dexamethasone in particular, just how much it really hits growth. And this is not just for the course. While we're giving them the steroid, we see these effects that persist as well once they're even off the medication. So ultimately, growth is influenced by many different factors. Nutritional provision certainly is important and should always be prioritized. But it's also common to have infants with BPD that show signs of growth failure or disproportionate growth, even when we're giving them all the nutrition that we can. And that's when it's really important to consider all these other factors that really do influence growth, because a lot of them are potentially modifiable. I think the other aspect that I wanted to touch on is just how important a chronic care model is for treating patients with BPD. Because the mindset of slower respiratory weaning and frequent respiratory weaning really allows for these patients to reach a place where they can be stable from a respiratory standpoint and use less energy, for work of breathing and just everyday survival, and really end up focusing more on being able to grow. So I think a chronic care multidisciplinary approach really is important when it comes to managing these patients with BPD, which can be challenging because it certainly is not how most acute care NICUs are set up. Okay. So now I just wanted to transition a little bit and talk about how we can optimize nutrition delivery in these patients and improve their outcomes so that they start to have more proportionate growth, like this cute little guy here. So we know that BPD is a chronic disease, and it takes a very long time for our patients to show signs of improvement. I like to think about BPD as having 4 main phases within severe BPD that all patients will go through on their road to recovery. And as you can see from this chart here, each of these phases takes quite some time. So we're talking more like months to years as opposed to days to weeks with these patients. And the nutritional needs of patients change as they go through these phases. And so what I wanted to focus on today is going through these phases, how we can recognize the phase that the patient's in, and how we can change the nutritional management based on their clinical stability and their age as they work through. And I am going to use a case example as well to help us go through these phases of a patient that was discharged here just a few months ago. So patients who are in phase 1 or the acute phase of BPD are critically ill. This phase is characterized by a really high oxygen need, respiratory instability, and significant work of breathing. These patients often require steroids and often require IV sedation, and in the worst of the worst, require paralysis as well. Pulmonary hypertension is commonly seen in this phase. About 1 in 4 patients will have pulmonary hypertension. And so how growth looks in this phase is not great. So the growth in this phase is very variable and it's pretty poor overall. It's common for patients in this phase to have a lot of edema, especially in the head and neck. And this significantly impacts the weight curves that you'll look at. So the weight trends might be all over the place depending on the edema. And in general, these patients are exhibiting very poor, if any, linear growth. So this sweet little girl is the case we're going to talk about today. She was born at 25 weeks, was admitted to our BPD unit at almost 41 weeks PMA. She came to us intubated. Her FiO2 on admission was 0.7. She was on chronic systemic corticosteroids, and she was on IV sedation, and she was also pharmacologically paralyzed on admission. So this was her nutritional regimen. Prior to admission, she was receiving 120 mils per kilo per day. She was receiving maternal milk with HMF fortified to 24 kcal per ounce, overall giving her 96 kcal per kilo per day and 2.4 grams per kilo per day of protein. On admission, our dietitian did change her over to a little bit of a different approach. She increased the total fluid slightly to 130 mils per kilo per day, increased the fortification up to 26 kcal per ounce, added MCT oil, added zinc, which we'll talk about a little bit later, and ultimately this brought her up to 120 kcal per kilo per day with 3.3 grams per kilo per day of protein. So bringing her up to more of the recommended range that we like to use with our patients. So with these initial changes, just in the first few weeks, her weight score did gradually improve. Her Z-score was negative 0.7 and did get to 0. And also her linear growth did show signs of improvement early on, with the Z-score going from negative 2.6 up to negative 1.6. So she did pretty quickly show a response to these nutritional changes. However, at about 4 weeks after her admission here, she experienced pulmonary hypertension crisis, as we often see in this phase 1 acute period. And as you can see here, her linear growth really leveled off during this time. Also during this time, she really started to develop more head and neck edema, as you can see in this picture of her. So through her pulmonary hypertension crisis, she was started on inhaled nitric, which did help her clinically and helped her in terms of evidence on echo. Her edema just continued to worsen, as you can see here in this picture, and ultimately she ended up on 3 times a day Lasix. She was also had a prednisolone burst during this acute phase that was slowly weaned down over 2 weeks. So she went from a burst of 2 mg per kg per day down to 0.2 mg per kg per day. During this time, she was also showing some signs of GI intolerance, which is very common in our patients anytime they're going through acute phases of illness like this. So mom kind of latched on to the HMF being a problem for her. And despite our counseling, eventually we ended up taking her off HMF and changed her to a different fortifier. So we were able to maintain her calorie intake during this phase, but unfortunately her protein intake did drop down a little bit during this short phase. And we did try to supplement with liquid protein, but she didn't tolerate this as well. I will say, though, even through this acute phase of illness, she was able to maintain on full enteral feeds without any parenteral nutrition, despite how clinically severe she was. And she very beautifully demonstrated the classic growth trends that we see within this acute phase of BPD, where we really just see poor weight growth, poor linear growth. As we know, growth is impacted by illness severity, stress, hypermetabolic states, corticosteroids, all the things that she was experiencing, and her growth really reflected that. So when caring for patients that are in this phase of disease, it's important to just make sure we're providing calorically dense feeds and we're optimizing protein with the goals listed here. We try and target calorie intake between 120 and 150 kcals per kilo per day, and try and get protein intake up to 4 grams per kilo per day whenever possible. It is very safe to continue enteral feeds through times of acute illness. And in fact, the frequent discontinuation of feeds just worsens the growth status, right? And so we will feed our infants enterally through all periods of acute illness, including pharmacological paralysis. We'll feed them through that. And we also know it is safe to feed these patients gastrically. And there is some literature that shows infants who have BPD that are fed transpyloric feeds actually end up having more desaturation events compared to those who are fed gastrically. So we prioritize gastric feeding as well whenever possible. So when it comes to feeding selection and modular components, here are some options I've listed here for you. For the patient that's on maternal milk or donor milk, certainly, of course, as we all know, fortifier is needed in order to achieve that higher caloric density. If there's a patient that is on donor milk that is not growing well, at this point, we would usually just take them off donor milk and transition to formula. And that's because these are patients, if you remember, these are patients that are already 36 weeks PMA or older, and then they're outside of that risk for NEC. Additionally, it's completely okay to use high protein preterm formulas past post-turn age. And so we will usually transition off preterm formula more towards a transitional formula after a few months corrected age. So just because they hit 40 weeks corrected or term corrected does not mean they need to completely come off preterm formula. There is some wiggle room there. And then we wouldn't go to, I wouldn't recommend going to like a term formula. I would recommend using more of a transitional formula or what they call discharge formula. And I think of those formulas as more preemie light because they have higher energy, higher protein, higher minerals than standard term formulas. So they're kind of in the middle between preterm formulas and term formulas. Also, there's other options for modular components if you still can't meet goals. For example, protein supplementation with liquid protein can be really helpful if you want to increase your protein content for patients when you're already maxed out on fortifier. And sometimes we will use MCT oil as well for extra calories if you're trying to get the overall calorie goal up. It's more of a second choice than protein, but a lot of patients do kind of struggle with tolerating protein. So there's lots of ways to make sure patients are getting what they need. Okay, so we know patients are transitioning out of that phase 1 acute period into the more transitional phase 2 period when we start seeing just the tiniest signs of more clinical stability. So this is characterized by weaning oxygen, improved respiratory status, and improved work of breathing. Certainly not all the time, but throughout the day, the patient will have periods where they are calm and comfortably breathing. Also during this phase, you see that the team's able to start weaning sedation and steroids. Certainly the pulmonary hypertension is getting better if it's present. And also in this state, really start to see patients have improving developmental capacity, which is so exciting that they're able to start participating in therapies and that they tolerate their cares better. So the growth during this phase is different. It usually starts improving from a weight trend standpoint. At the beginning of this phase, you might not see any linear growth, but towards the middle and end of this phase, linear growth will slowly start to improve. Okay. So for our case, during this time for her, she did start to show some emerging respiratory stability. She did have weaning FiO2 needs. She was able to maintain at this low dose of prednisolone, didn't require any bursts. We were able to wean her Lasix, and because she was more stable and she was quite older in age, we were getting ready to proceed with tracheostomy with her. So during this phase, for nutrition, she was receiving total fluids of 125 mils per kilo per day. She did start to show clinical stability and overall GI improvement, so mom was comfortable adding back HMF. So we went back to HMF at 26 kcal per ounce, continued MCT oil, and ultimately this gave her total calories of 115 and 3.1 of protein. And she read the book and followed the growth trends that we usually see in phase 2 as well. As you can see in this first curve, this is her weight curve, and she is starting to show slow improvement during this time. And the curve next to it is linear growth, and it has, as you can see, it was completely leveled off. Now during this phase, she has started to have the slow start of linear growth, which is what we expect during this time. And so when it comes to the overall management approach for these infants in this phase 2, the overall needs, the way I think about it is the overall needs just decrease slightly. Slightly less fluid, slightly less energy, slightly less protein. And then, of course, we'll talk about monitoring in a little bit, but of course, you're monitoring these patients' growth trends as you're making these changes to determine if they're at a point where they can tolerate a little bit less nutrition or if they just need to stay at the higher volumes. Okay. So we know patients are transitioning into phase 3 or the pro-growth phase when we start to see that their oxygen needs are stable. They're not there's not a lot of variation in them. And when the patient is comfortably working to breathe at all times. Most patients at this time are completely off steroids and either off or weaning sedation medications. Certainly, if pulmonary hypertension was present, it's now resolved. And we really start to see patients take off developmentally in this phase, which is so fun to watch. The growth trends in this phase, usually you'll see consistent linear growth. So not just that slow uptake you see in phase 2, but now consistent improving linear growth. And most importantly, these patients will show improving weight for length trends. So we start to see an evening out between their weight and their linear growth trends, as opposed to those babies that have really high weight trends and low linear growth. It starts to become more proportional. So our patient during this time, she was no longer on nitric, she was off sedation, and she was off all her steroids. Her FiO2 needs were stable between 25 and 30%. Her BPD pulmonary hypertension had resolved on echo. And at this time, we were focusing on ventilator weaning and working towards getting her home. So her nutrition during this phase, her fluids were at 120. Our calories were dropped a bit, so our HMF was still being used, but we were fortifying 24 kcals per ounce, mixing this with a post-discharge formula due to mom's low milk supply. She was off MCT oil at this time, and her overall intake was 96 kcals per kilo per day, and her protein was 2.7. And we saw that she demonstrated what we would expect for her growth trends during this phase as well. So most patients with severe BPD will have a very high weight to length ratio because of that persistent high weight gain in the setting of very minimal linear growth. However, during phase 3, what we should start to see, which she shows us here, is that this ratio should gradually start decreasing as growth becomes more proportionate. And she did a great job of showing that for us here today. And as we see this ratio improve, it tells me many things about the patient, that we're at a good fluid balance, that we know this patient's having consistent linear growth. We know that inflammation is low. It might not be gone, but it's lower than it used to be. And what's really fun during this phase 2 is as these trends improve, we really see just more core strength and motor skills develop, and these patients really take off developmentally. So the overall approach within this phase is similar to the one before it, where you're reducing energy and protein needs even a little bit more as the patient is becoming older and as the patient is having more clinical stability. There are still some challenges within this phase, though, and one in particular is oral feeding. So most of our patients do not need a tracheostomy like this case did. Most of the time, they're able to wean from the ventilator to CPAP to low flow cannula and start working on feeds. And what we will sometimes see during this phase while they're working on feeds is these patients just have decreased feeding endurance. They're working harder to breathe while they're feeding. It's taking them a long time to get through the feed. And so there does still need to be close monitoring of calorie needs during this phase. And for patients that are really burning a lot of energy working on feeds, they just might need some more energy, which is why the range here from 70 to 120 is so big. Because initially you might think, well, that's not helpful, but there is a range depending on what the patient is doing in terms of oral feeding and also their activity level. Okay, and lastly, in phase 4, or the convalescent phase of BPD, these patients are home. They're working on nutrition in the outpatient setting. I didn't have time to dive into this in detail today, but if anybody is interested in learning more about how to manage nutrition in the outpatient setting, please feel free to email me and reach out to me. I'd love to talk more about that at another time. For our case presentation, she went home on CPAP pressure support mode on the Trilogy and was very easily and quickly able to progress to missed collar once she got home. And this was her nutritional support on discharge. So she was receiving 120 mils per kilo per day, 80 kcals per kilo per day, and a protein intake of 1.7 grams per kilo per day. She went home on term infant formula, and she was receiving 7 feeds a day. She's doing taste of baby food, which mom just loved to do. And of course, she went home on vitamin D. And these are some pictures of her, very sweet and happy at home back in very sunny Florida. Her mom is wonderful and sends us pictures all the time, and it's just so great to see how well she's doing. Okay, so also wanted to switch gears a little bit and talk about how to monitor these patients from a nutritional standpoint over time and how to know when to start making these changes, in addition to the clinical changes you're seeing in terms of their stability. So of course, routine monitoring of anthropometric measurements is key. It's the best way to assess overall nutritional status and growth. And so in addition to weight, length, and head circumference, I find it really helpful to follow weight for length curves over time. As with BPD, we tend not to see so much just traditional growth failure, but more disproportionate growth. And so I find that curve to be really helpful once we're able to switch over and use the World Health Organization growth charts. And in order to rely on these measurements, especially linear growth, there needs to be a way to have a standardized protocol in place on how to accurately collect these measurements week in and week out. And so the recommended practice for length measurements is to use length boards. And this can be used for all patients, even patients who are intubated, even patients who are going through phases of clinical instability. So length measurements should be completed by 2 trained adults and is often completed with a combination of nurses and or our dietitian will do length measurements. And we have also found it really beneficial to train our parents as well to obtain length measurements with a nurse or with our dietitian. We found that they're able to do it just as accurately, and it's just another way for them to feel involved and to feel like they can do more as a parent. So a lot of our parents will do the weekly length measurements with the nurse. So when you have patients that are showing disproportionate growth, as we know, this can be really difficult to determine. Is this a patient that's having a lot of edema, or is this a patient that really is decreasing their energy expenditure and we need to adjust the calories that we're delivering? And so when trying to figure out which way we're going, in addition to looking at clinical indicators that we talked about in terms of disease phase, um, what I like to follow is mid-upper arm circumference measurements. And this can be really helpful because this area is not impacted by fluid status, so it's not impacted by edema. It is more reflective of true weight gain. It is independent of corticosteroids, and it's very closely correlated to BMI. So I think when you're in this phase and you're not sure which direction you're heading, it can be really helpful to get like a weekly mid-upper arm circumference measurement, follow that over time to see which way the patient's heading. I also think it's important to remember the patient's age. And as patients age, their recommended optimal weight gain rate changes. I think, myself included, as neonatology providers, sometimes we can get stuck into thinking 20 to 30 grams per day forever. But really, once the patient reaches term-corrected age, their weight gain recommendations changes away from kilo-based and decreases as they age. So for our patients that are with us for quite some time, we just can't have the same expectations for weight gain, and that might be getting us into trouble with giving them too many calories for too long. Something to consider. Okay. In rare cases, when we're still struggling to determine how many calories a patient needs, sometimes IC testing can be used. This is also called metabolic cart testing. It's very popular in the PICU. And this is a test that ultimately measures resting energy expenditure for patients that are on mechanical ventilation. And it does this by measuring the volume of oxygen consumed and the volume of carbon dioxide produced. And through these calculations, it tells you the resting energy expenditure. We've trialed this on many patients within our unit, and I know some other centers are trialing this as well. And we've had a few patients where it helped, but most of the time we were getting very inaccurate results with either an overestimation or an underestimation of calorie needs. And this is just ultimately because this is a very sensitive test, and there are many factors that impact how results are obtained. So this is not something that we're routinely using. This is more for that really difficult patient that we still can't figure out which direction we need to head in. We might try this on. When it comes to laboratory monitoring, certainly intermittent testing can be helpful to assess nutritional status, especially for infants who have chronic fluid restriction, diuretics, or are on certain supplements. Electrolyte monitoring is certainly essential for patients on diuretic therapy, as they're often going to need potassium chloride or maybe even sodium chloride supplementation. BUN and prealbumin can be helpful to give you an indication of protein intake and protein status if there is ongoing concern for linear growth. I don't tend to use albumin much. It tends to be more reflective of illness severity rather than true nutritional status, and it's confounded by so many things that I find it very difficult to interpret. So if we're thinking more about, looking at protein status and overall nutritional intake, tend to focus more on BUN and prealbumin. And then certainly if there are other concerning factors that we're concerned about, such as iron deficiency, we can check ferritin, hemoglobin, and hematocrit, of course. We as a group tend to try and limit painful procedures like lab draws within our population because we know that the more painful procedures patients have in the NICU correlate to poor long-term neurodevelopmental outcomes. And so we try to batch these labs when we need to get them. And usually for our patients in the most acute phases, like phase 1 or phase 2, we're getting labs weekly. And then when patients space out into phase 3 and 4, we're getting them much less frequently, if at all. So I did just want to quickly touch on the importance of zinc with BPD. So there's a very big growing interest in the role of zinc in infants with BPD and how it impacts growth. So we know that patients with BPD are at high risk for zinc deficiency. We know that zinc is very important and involved in many functions. So it's important for protein synthesis, enzyme function, tissue repair, and growth. And for board purposes, for neo-board purposes, we know that older infants may show signs of zinc deficiency like dermatitis or diarrhea, having frequent infections. But for the younger infants or early stages of zinc deficiency, you don't really see those signs. And sometimes they can present simply as just poor growth in the setting of optimal nutrition. We do have data that shows zinc supplementation in patients with BPD does improve growth outcomes. So this is a study that examined weight gain before and after zinc supplementation for patients with BPD that had poor weight gain. And all these patients were of similar gestational ages. They received the same nutrition throughout the study. So the only really changing factor here was zinc supplementation. And we found that it did improve weight gain significantly, and it also improved linear growth significantly. So I think it's very reasonable to consider almost empiric zinc supplementation in BPD patients with poor growth, certainly if they're on diuretics or if they have an ostomy, because this can increase zinc losses as well. So there's currently no consensus on dosing or duration for zinc use with patients with BPD, although there are a couple ongoing research efforts within the BPD collaborative to look at this. So if you're interested in this topic, let me know. Love to have you involved. So I do want to share just our practice, but remember this is not evidence-based. We would like to use zinc acetate, 10 mg per ml concentration. We'll use about 1 to 1.5 mg BID. At this point, we're using flat dosing because patients are older and bigger. And then we will continue zinc supplementation until growth is consistently better or the patient is getting ready to go home. And lastly, we know how important metabolic bone disease is, especially for patients with BPD. 60% of patients with BPD have metabolic bone disease at 36 weeks PMA, which is just so high. This is compared to about 35% of preterm infants who don't have BPD. We know there's significant short and long-term implications of this disease. So it's important to do routine screening for these patients. That includes ALK-Phos screening, phos, and calcium screening. The treatment for metabolic bone disease certainly varies based on your institution. There's probably a policy in place at your center, but it's usually a combination of either feeding changes or supplementation of calcium, phosphorus, or vitamin D. And then, of course, continue to wean diuretics and steroids if possible. Okay, so very quickly, I just wanted to share a little bit about our unit. We were founded in 2005. We're a 24-bed unit. We have about 130 patients each year admitted to our unit with BPD. And this is a combination of both patients from Ohio, but also we are a large national referral center. And so we take patients from all over the country. And this group of patients that are national transfers are a very challenging population to care for. They're often much older, well past 36 weeks PMA, have the most severe forms of BPD with many comorbidities, and a lot of them already have a tracheostomy as well. So my colleague, Dr. Keel, looked at many outcomes for this unique population of national referrals, including growth outcomes. And so this graph represents a cohort of 65 patients with moderate and severe BPD admitted to our unit over a period of about 8 years. And this graph is only showing survivors, which was 92% of the entire cohort. 6 patients had passed away during this time prior to hospital discharge. And what this graph shows is Z-scores on admission and then Z-scores on discharge plotted on World Health Organization charts for weight, length, and head circumference. And as you can see, median Z-scores improved significantly across the board for all of these domains. And this was, these patients were all managed using the approach we talked about today. So in summary, I just want to say that nutrition is one of the most important aspects of BPD management. It impacts our patients in the moment and then also for years to come. How we manage these patients nutritionally evolves as the patient evolves through the disease course. And certainly we need future studies to further define just how best to treat this population. Thank you so much for your time.